This is an interesting question because we want to reduce toxicity of novel regimens, but to harness the engraftment and then also the graft versus leukemia effect. So therefore there are novel agents coming in the market which are used in treatment from leukemia, for instance, which can be incorporated also in the conditioning regimen. And we have novel agents like treosulfan, for instance, which has a very good toxicity profile. This is something we can do already today, but in the future we want to get rid of chemo at all. So they are antibody-based or antibody-drug conjugated and targeting CD45, which is expressed on all hematopoietic cells. And also there is recent development in editing CAR T cells with CD45, which might be also a good option in the future to use it as conditioning regimen, which is chemo-free. I think they already do, at least in acute lymphoblastic leukemia. So currently the CAR T cells which are on the market and have shown efficacy are either targeting B cells, CD19, or they're targeting BCMA, which is expressed on myeloma cells. So in myeloma cells, allogeneic stem cell transplantation is a rare indication, so there is no need to overcome this indication by CAR T cells. But in lymphoblastic leukemia, we know already that in relapsed patients, they can replace allogeneic stem cell transplantation. It's not so clear whether CAR T cells is enough or whether patients need also an additional allogeneic after CAR T cells. This is currently a question of clinical investigation. But it's more likely that at least in acute lymphoblastic leukemia, it could replace allogeneic stem cell transplantation, at least in part. Yeah, if you talk about complication, I think the most promising approach with cellular therapy to avoid this complication are infectious complications. So we have now options to use T cells or specific T cells against EBV, for instance, for EBV-related complication after transplantation, but also for CMV-specific T cells or other viral infection. I think this is the most promising development. On the other hand, we will have also development immunotherapies to avoid relapse. Yeah, for instance, CAR T cells and other immune checkpoint inhibitor, for instance, to prevent relapse after allogeneic stem cell transplantation.